There we are. Welcome to the narrated PowerPoints for care of the veiled client with reproductive problems. I am your host, Miss Lydia Tonis, and let's go ahead and begin. I'm going to actually begin with report. I hope you have a piece of paper ready, and if not, press the space bar and we'll pause the video here. So let's begin. Mr. Jones is a 68-year-old male who is being seen in your clinic for a routine health checkup. He reports that he has been feeling well and has no specific complaints except for some trouble emptying his bladder. He has had a CBC and a CMP 1 week ago. His results are as follows: sodium 140, potassium 4.2, chloride 100, bicarbonate 26, BUN 22, creatinine 0.8, glucose 94, red blood cells 4.2, white blood cells 7,400, hemoglobin of 15.2, hematocrit of 46, and platelet level of 348. His PSA was 0.23 and his urinalysis was within normal limits. His vital signs are 148/88, heart rate 82, respiration 16, and his temperature is 96.9. What can you tell from Mr. Jones's lab work? Well, that everything is completely normal except his PSA. PSA stands for prostate specific antigen, and someone who is 68 years old, it should be from 0 to 1. What is the prostate specific antigen? Well, it is an antigen that is produced exclusively by the epithelial cells of the prostate, the periurethral and perirectal glands. It's used in conjunction with a digital rectal examination, and it's useful in screening for early detection and possible monitoring of cancer of the prostate. But do be warned, it is a non-specific indicator of prostate cancer. It helps, but it's not specific. Okay, here we have a picture of a prostate dissected, and as you notice, the prostate cells tend to grow in number, and they will grow towards the inside of the urethra, making it a narrow space. I'm going to now use the term BPH instead of saying benign prostatic hyperplasia, because that's a bit of a mouthful. So BPH may be related to androgens and aging. Here, the cells will undergo hyperplasia, causing local inflammation. Problems with BPH include increased urinary stasis and chronic urinary retention. This definitely sounds like it puts the person at risk for a UTI and stones. In acute urinary retention, we find that this is an emergency problem, and it's the reason being it's going to cause hydronephrosis, hydroureter, and can possibly lead to kidney failure. Anybody want to take a guess at what overflow urinary incontinence is? This is when the bladder continuously has a little bit of urine in it at all times. It's never fully emptied, and unfortunately when a person has overflow urinary incontinence, they will leak urine unintentionally because the bladder is so full and unfortunately incompetent. Okay, here. Okay. Here I have a picture demonstrating the normal anatomy of kidneys all the way down to the bladder and to the prostate as compared to someone who has complications from BPH. As you see here, the renal pelvis is going to be dilated. This is also known as hydronephrosis. And then here, whenever urine gets backed up in the ureters, it actually becomes what's the word I'm trying to look for? Okay, we're going to go with curvy, and this puts the person at risk for urinary stasis and stones. The bladder is actually going to enlarge. This is due to the constant urinary retention. In doing so, the bladder wall here is going to get thicker and less effective at emptying the bladder. Here are some symptoms. Of BPH. A person is going to have hesitancy. This is where they have difficulty in starting or initiating a stream of urine, or even continuing the stream of urine. It's going to come out in little spits and little spurts rather than one stream. Their stream is going to be weak. This is where they have reduced force and size of stream. They're going to have a sensation of an incomplete bladder emptying. So you go to the bathroom, you feel like you need to pee, you perform, you void, and then you feel like you still need to pee. So sometimes our gentlemen will stand in the bathrooms for a long time till they feel that sensation go away, which may not even completely go away. Very frustrating for a patient. Straining. This is when a patient oftentimes will grunt or use abdominal muscles to begin the urine stream. So do they complain of straining? Lastly, post-void dribbling. This is often due to the overflow incontinence that a patient will experience. So they will urinate, they feel that everything is empty. However, when they go to pull up their pants or zip up their zipper, they will then void a little bit more unintentionally. The last one here, hematuria. We will notice hematuria at the beginning or the very end of a stream. This is very common in our older men with BPH, and this is because of the straining that they have to do to be able to urinate. Another thing we can do is perform abdominal palpation, and we're going to be assessing for a full bladder, and you're going to feel that right above the symphysis pubis. In obese patients, it may be a little bit more challenging to palpate or even percuss this area, so you may choose to do a bladder ultrasound. History. There is a very reliable scale that comes in various languages for patients who are of advanced age to help us understand the degree of difficulty they're having with their prostate. They do say that most males actually have issues with urinating, and so this is a very good scale to use. We oftentimes will see it more in a outpatient clinic rather than inpatient clinic. Okay. Your physical exam includes a digital rectal exam, and this can only be done by a licensed practitioner, such as a PA, nurse practitioner, or even a doctor, an MD. And screening often begins for males when they turn 50 years old. The nurse's responsibility is to assist with the digital rectal exam if that's necessary. We will inform the patient that they may feel the urge to urinate when this is being performed. We help get them in position by bending them over, or they may possibly go into the side lying fetal position. The prostate, when felt, if it just has BPH, should be uniform in texture. It should be elastic-like, non-tender, and of course enlarged. If it is stony, hard, or even painful, we are very suspicious that it's cancerous. Now, prostatitis is inflammation, possibly infectious inflammation of the prostate, and this often occurs with BPH. So a provider may massage the prostate gland and the nurse is there to help collect the prostate fluid and send it off for culture and such. Psychosocial assessment, I wouldn't be surprised, or we shouldn't be surprised, that the patient is going to be irritable, depressed, maybe even moody from the lack of sleep. They will definitely be embarrassed because of the urine smell and the constant dribbling in their pants. Do ask the questions about the impact of the BPH on their life, because there is a high correlation with BPH and depression, and they may need additional support. Labs that we're going to perform on this patient include a urinalysis. Do you know the reason why? It's because they oftentimes will experience UTIs from the urinary retention, so we're suspicious that they will have bacteremia, or bacteriuria, excuse me. We are also going to be looking for hematuria and a white blood cell count, indicating a UTI. The CBC, we're going to be assessing for anemia and systemic infection. And the reason for the anemia is they do have a little bit of bleeding, sometimes at the initiation and at the termination of the urinary stream. However, occasionally a person can bleed a little bit too much. So we would assess for anemia related to the bleeding that they may have. And also the white blood cells to assess for systemic infection, specifically urosepsis. Okay, the BUN and creatinine, we are assessing for kidney disease due to the urine not being emptied and backing up. The PSA, this is if cancer is suspected, but do remember it is sort of non-specific. It naturally rises in older adults and in men who are of African American ethnicity. It is naturally higher. So someone who is older will actually have higher normals. So the normals are relative to somebody's age. We may possibly collect the prostatic fluid. This is if prostatitis is suspected. We can also do, I'm trying to see if I have it listed here. I do not. But we can do a urodynamic flow study. This measures somebody's urine stream flow rate. So they actually pee, and we'll measure how fast and how strong their urine stream is. So I don't have it listed on here, but that is another study we may do. We have the TRUS examination. This stands for transrectal ultrasound. This is where we will insert a probe into the rectum looking for size and configuration of the prostate. We may also do a biopsy and a cystoscopy to look at structure. And then of course the easiest one, this is that nurses can do, is we'll do a bladder scan looking for residual urine. Here's a question for you that I will read. When assessing the patient with benign prostatic hyperplasia, what assessment finding would the nurse expect as typical? Rectal bleeding, distended bladder, tenderness over the kidneys, or enlarged painful prostate gland? There it is. Distended bladder. Answer B. Although the prostate gland will be enlarged, it is uniform, elastic, and non-tender. With prostate cancer, the prostate feels like a stony hard nodule. In patients with BPH, that distended bladder would be expected. Rectal bleeding would probably be an indicator of prostate cancer because it is metastasized. Tenderness over the kidneys would indicate pyelonephritis. And that would indicate cancer. One of the first things that we will probably do is pharmacological management of somebody's BPH symptoms. So we definitely need to improve their urinary elimination. That is our priority. We prefer the patient to not have any urinary hesitancy, urgency, and infection. So what drugs are we going to give them? We're going to begin with 5-alpha reductase inhibitors. Meaning what it does is it blocks the effects of dihydrotestosterone, or DHT, and androgen on the prostate, because that is exactly what is making the prostate grow. It can take months to work. In fact, a patient may not see any kind of relief from their symptoms up to 6 months. So they have to stay patient and stay with it. Finasteride is a very popular drug, also known as Proscar. Do note that females are not supposed to handle this with ungloved hands or crushing this medication, because it can be teratogenic. And that is finasteride. This one right here, tamsulosin, is an alpha-1 blocker, and it relaxes smooth muscle in the prostate, lessening resistance. Unfortunately, tamsulosin is a medication that also affects the blood pressure. So we need to warn the patient of orthostatic hypotension, tachycardia, and syncope. The recommendation is that patients take this medication at night to reduce the adverse effects. We do want to make sure to monitor somebody's liver function with both of these, finasteride and tamsulosin. And the best therapy is a combination of finasteride and tamsulosin. Saw palmetto is beginning to have some prevalence in terms of patients are reaching out for this over-the-counter medication. Scientific evidence is lacking in terms of it being effective for most patients who take it. So the recommendation is that patients buy it from a reputable source, and they stop it before procedures, because saw palmetto has been shown to thin blood a little bit and make them more prone to bleeding. Good news, frequent intercourse can actually improve symptoms. The way that this works is frequent intercourse releases prostatic fluid, thereby shrinking the prostate so slightly so males can have relief when they need to urinate. This one's important. Patients with BPH need to avoid alcohol, caffeine, diuretics, and some over-the-counter medications such as antihistamines. Do I have that there? Yeah, antihistamines and decongestants. This medicine right here, Detrol and Ditropan, these are anticholinergics, and their use is actually for patients who have urge incontinence, where they need to pee 20 times a day, or they feel like they need to pee 20 times a day. This medication will actually cause this patient to have urinary retention. So please pay attention to the medications that these patients should avoid. I guess I should explain the reason they have to avoid alcohol, caffeine, and diuretics is because these are going to require them to make frequent trips to the restroom, which we do want them emptying their bladder, but not excessive amounts. There are a few minimally invasive options that a patient with BPH can have done. If you want to read more about this, it's on page 1479 in the left-hand column. We're going to focus on prosthetic stents, the TURP, and the HOLEP procedure. prosthetic stents maintain patency. There is less risk for erectile dysfunction and post-op bleeding. A patient can return to activities quickly, and this is a great option if a person is a poor surgical candidate. And it does temporarily relieve obstruction. The downside is some patients can pass the stents, meaning they'll need to be replaced often. Pass through their urine, they'll pee them out. Surgical management. So patients who don't want to take drugs or aren't candidates may possibly do a TURP. This is the most common and most effective long-term approach. The TURP stands for transurethral resection of the prostate. There it is there. So the prostate is removed in chips. There won't be an automatic loss of sexual function, and permanent incontinence won't always occur, but we make no promises. You want to make sure to assess their knowledge and correct misconceptions and provide accurate information. I know this sounds like the job of the doctor, but we do reinforce this information a lot. This isn't a procedure that's a one and done type of procedure. A patient can actually have multiple TURPs done. It is very traumatic to urethra, and you can anticipate lots of bleeding. However, do note that the bleeding is usually just going to be tinting the urine. What I would be nervous about is if I saw ketchup-like drainage. The patients need to make sure they increase their fluid intake, so they need to drink. No enemas after this procedure or laxatives. They need to take stool softeners only. They need to avoid lifting, so nothing heavy. And they have to abstain from sex for a few weeks until this is healed. Some patients do discharge home with a urinary catheter, so please don't be quick to pull this catheter out. It is common after a patient to have a TURP to have a 3-way bladder irrigation set up. Sometimes we call that a Murphy drip. I don't have a picture of it here, but there will be 2 bags connected to the patient's Foley. The bags are hung on the IV pole, and they are actually allowing normal saline to flow into somebody's bladder, and it is acting as a flush mechanism because a patient is slowly bleeding where they had the pieces of the prostate removed. And if a patient isn't actively passing the blood sitting still for any period of time can clot off. And we definitely don't want a clot sitting here or here or here, because the urine is just going to back up and potentially get backed up into the kidneys, causing hydronephrosis. So the 3-way catheter flushes saline in here, and with the catheter, it comes right out into a bag, like a Foley bag. The Foley bag is quite large, just FYI, and you have to empty it frequently. Because this is a bloody procedure, do monitor someone's H&H, and you're probably going to withhold all anticoagulants such as Lovenox and heparin, and Plavix and aspirin. Please be sure to visit this chart to see all of your do's and don'ts in caring for someone who has a TURP. The other procedure that is gaining popularity is called the HoLEP. It stands for holmium laser enucleation of the prostate. This is when a laser will zap the tissue and push it into the bladder. There is little blood loss, and patients can return to work much faster. External condoms are discouraged if patients have BPH. Another question. The nurse understands that the patient who has undergone a TURP is at risk for developing which priority concern? Pain, infection, hemorrhage, bladder spasms. Do note that all of these are concerns following our TURP. Which one do you feel is most important? Hemorrhage. The reason for this is because this is more life-threatening, the hemorrhages. But yes, all of them are important and all of them can be managed with either medication, repositioning, or aseptic technique. I didn't mention it on the previous slide, but do make sure the three-way catheter is taut on the leg, meaning there is traction applied when the doctor places the leg stabilization device for the Foley or the three-way catheter. Make sure that it is taut and not out just flopping around. That assists with pain management and it helps with the bleeding. For bladder spasms, we can give our patient something called B&O suppositories. If I understand this correctly, it stands for belladonna and opium suppositories. Because of the opium in it, it does have an effect on somebody's blood pressure and respirations, so make sure those are stable before administering a B&O suppository, but it works very well for a bladder spasm. And the best way to treat a bladder spasm is prevention. Prevention includes monitoring for full bladder, monitoring for UTI, and making sure that the catheter is taut. So if you can take care of those things, you may not even have a bladder spasm.